The next session, from melt to mend, a practical guide to corneal perforation repair. So I would first call our first speaker, Dr. Prabhakar Singh. He's a assistant professor at AIMS Kalyani, to proceed with his talk.
Very good morning. So today I will be talking on the first response in corneal perforation, and we will also touch upon the causes of cracks in the clear shield, that is the cornea. So let us talk about a hypothetical situation wherein a patient comes to the ER, that is the emergency room, with breathlessness and a bleeding eye. Now the intern watches carefully and decides that the bleeding eye needs treatment, and the patient is sent to the ophthalmology ward. Now that is where the patient succumbs to the injuries that the patient had. So what was the problem behind? Probably the dyspnea was never evaluated. He saw the bleeding eyes and just went for the ophthalmology referral. Now what could be the reason behind? It could be a flail chest, it could be a pneumothorax. That means these are the life-threatening conditions. So always triaging is the first thing that has to be done in cases where there is polytrauma. As far as once we have already done the triage, we know now the patient is systemically stable and we can safely take the patients to the ophthalmology OR for further management. Do also inquire about the vaccination status of the patient, whether the patient had received injection TT in the last 5 years or not. If not, then you also need to give injection TT. Yes, once we are done with these two, we have to do a quick evaluation on slit lamp and see what is the extent of the trauma. How far is the trauma has caused damage to the patient's eye. And based on that, we'll have to explain the prognosis to the patient and their relatives as to how much vision they are likely to get after the surgery, or what would be the final prognosis. Yes, now once we are done with the triaging, giving injection TT, we have assessed the eye, and based on that we have also explained the prognosis to the patient. Now the patient is supposed to be shifted to the ophthalmology ward. Now this is when one has to be very careful. Do not patch the eye. Do not patch the eye. This is something very, very important. Rather, place an eye shield over the two bony prominences, that is the frontal bone and the malar bone. And the eye shield should rest on these two bony prominences and never ever patch the eye. And definitely, there should be absolute no to topical antibiotics in this scenario, because we have come across many cases when now the patient, considering the fact that the patient had some trauma, patient has been started on everything possible, starting from antifungal, antibiotics, and everything. So remember, no eye drops to be given in patients where there is an open globe injuries. And definitely, you have to start the patient on systemic antibiotics as well after the admission. Always remember the fact that the moment the patient has come, it's your duty to inform the patient not to take not to take either a meal or a drop of water, because the patient, very likely in most of the open globe injuries, we have to preferably take these patients under general anesthesia for management, except few cases where there is very small corneal tear and there is no other concomitant injuries. And the most important part is the informed written consent that has to be taken, explaining the pros and the possible complications and the future outcomes that the patient can have. So what is the objective of doing all these procedures, all these things? The first objective when a patient comes with trauma is to salvage the organ, and that too, the primary repair should have an aim of complete watertight closure of the globe. So what are the causes which can cause this? Any blunt object can cause trauma, and with an inside-out mechanism can have rupture. There can be a sharp object, be it a pencil or a knife or a pen, can cause a penetrating injury. There can be a splinter which can go into the eye and can cause again, and can cause corneal trauma and perforation and be there as an intraocular foreign body. Or there can be a perforating injury or a mixed mechanism of injuries. So based on the ocular trauma classification group that has put forth 4 parameters, that is the type, type of injury it is, that is the mechanism that tells about the mechanism. Then what are the zones involved, what are the grades of visual acuity, and what are the, how the pupil, sorry, and how is the pupillary reaction. Based on that, one can prognosticate as to how the patient will behave later on. And remember, it's very, very important that the visual acuity at initial examination is considered to be the most reliable predictor of final visual outcome in open globe injuries. One more important thing that I forgot to mention earlier, that never ever overpromise your patient. Okay, always it's better to underpromise but never overpromise. And history is very important, where we tell about where we get to know about the mode, duration, and the injury, object causing injury, and it also has medical legal implications. Quickly go for the investigations like X-ray, CT to rule out any concomitant injuries of the orbital bone or fracture. Do a gentle B scan if possible, if the eye is not hypotenuse, or if the edges are infiltrated, go ahead with corneal scraping. As I said earlier, the primary aim should be a complete watertight closure of the globe. And remember 4 principles, and if you learn these 4 principles correctly, then you can do any sort of corneal tear repair. The first is the perpendicularity of the sutures. Your suture should be placed perpendicular to the tear margin. 90% depth, your suture should pass at a depth of 90% depth. If it is anything shorter than that, it can have a lambda sign, or that is what we call as weakening of the wound. And if it is anything more than that, that is a full thickness suture, there can be aqueous leaking out or infection seeping into the eye. The third important principle is that the suture should be passed equally on both the sides of the tear margin with respect to the posterior tear margin. And the fourth important principle is the zone of compression. Longer the suture bites, more will be the zone of compression. Smaller the suture bites, smaller zone of compression. So always there should be an overlap between the zone of compression. So accordingly, we'll have to place the sutures. I will quickly take you through this small video. Probably the video, can you just make it run? Excuse me, the video. Okay, fine, I can do it now. Do not do not instill topical betadine. That is that is what we do. We first wash the surface with the betadine, but do not wash with betadine. There should be thorough saline wash. Never catch hold the tear margin, otherwise you are going to lose the tissue and there will be a tissue loss and difficult to repair subsequently. Whenever we are passing sutures, always inflate the anterior chamber, then only titrate the suture tightness. Apart from that, always remember that there can be materials which can get incarcerated into be it lens matter or be it the iris. So always release those. And as I said earlier also, that one has to pass the sutures perpendicular to the tear margin. And one very important thing is that always at the end do inject some air into the anterior chamber to see is there anything still incarcerated in the wound or not. Here you can see when I'm injecting air, it is still not taking in the entire anterior chamber. It's not occupying the entire anterior chamber, and you can see a notch over here. So what we do is we release it again, and now you can see that the anterior chamber is filling completely, anterior chamber is completely filled by air. So this ensures that we have released everything from the wound. So with this, I would like to conclude. Thank you so much, and I'm happy to take any questions now.
Thank you, Dr. Prabhakar. A very lucid talk. Anybody, any questions from the audience? A very important point which he mentioned was we very frequently see patients coming to our clinics with corneal tear, and they have been patched with atropine ointment or antibiotics, which should never be done.
Right.
So if we don't have a question, I'll thank Dr. Prabhakar, and I'll call my second speaker, Dr. Pranita Sahai. Yeah, so she introduce yourself, and he'll be talking about ocular meltdown strategies for perforated corneal ulcers.
So good afternoon, respected faculty. So Dr. Pranita could not come to the personal conference. So I am Dr. Abhishek, senior resident from the same institute. Will be presenting the management of perforated corneal ulcer. Dr. Prabhakar has beautifully told regarding the etiology and how to manage the case. So we are briefly talking about how to manage all the perforated corneal ulcers. So perforated corneal ulcer can be central or peripheral. And etiology can be infective keratitis, neurotrophic ulcer, peripheral ulcerative keratitis, chemical injury, exposure keratopathy, severe dry eye disease, and keratomalacia. So risk factors, there is a report from RPC and risk factors for perforation microbial corneal ulcer in North India, in which there was lack of corneal vascularization and delaying in starting initial treatment and failure to start fortified antibiotics were significant for risk factors of corneal perforation. And microbial keratitis can happen if high steroid use is also there. So we have to look for the presence of hypopion infiltrates. And so what is the preoperative workup? So we have to see what is the location of the ulcer, size, shape, depth, what is the location of the perforation, size, shape, and what is the Seedal's test? Is it negative or pressure Seedal's is positive? Anterior chamber flat or shallow or formed, lens status, it is cataractous or it is pseudophakic, because as Dr. Prabhakar said that lens matter can come in and it can change the management. So posterior segment evaluation. So we'll first do the corneal scraping. Obviously microbial test is essential. Corneal scraping, gram stain, KOH is needed, and examination under microscope will do, and we'll get the reports in 1 hour, in half an hour, and we'll can start treatment if it has to be fungal positive or any gram positive organism is there. So posterior segment ultrasound we'll do a gently, avoid any undue pressure, because it can release the contents out from the eye, and should be done before any surgical intervention, because we have to rule out retinal detachment and also to prognosticate the case. So treat the cause. So perforated corneal ulcer can be infective keratitis. So in infective keratitis, we have to see by topical and systemic therapy and cartella sheet to be used. Sterile melt or dry melt is there, so lubricant therapy and steroids with vitamin C and doxycycline should be given. Immune mediated topical and systemic steroids and immunomodulators are the treatment. So surgically, depending on the size of the perforation is very important. So small size, less than 3 mm, 3 to 5 mm, more than 5 mm, and the location, central or peripheral. So less than 3 mm, we have the option of corneal gluing. We can use Teenan's patch graft. If it is intermediate, we can combine Teenan's patch graft with the corneal glue. And the Raj perforation, we do not have any other option rather than therapeutic keratoplasty. So if it is a peripheral perforation, then we can do a crescentic patch graft, or depending on the cause. So this is one case, 14-year-old male, history of multiple ocular injuries, with strabismus and VR with encerclage. Re-VR surgeries has also been performed with SOR. So there is high risk factors to develop a corneal ulcer, and developed neurotrophic ulcer. We can see there are sterile infiltrates and thinning, and very less, around 1 mm of perforation, but it is not looking, infiltrates are not there. So only sterile melt is there. He lost to follow-up and presented with corneal perforation. Size is 1 by 1 mm. So what can we do? We have to do, location is central, so corneal gluing is the treatment of choice. So this is how we do corneal glue. So in corneal glue, what is more important, that the surface should be dry. That is when the glue will polymerize. So we just dry the surface and put a drop of cyanoacrylate glue and put a BCL over it. So we can see the polymerization happening, and now the polymerization has happened and the perforation is sealed. So in this case, we do not, since AC was formed, so we do not have to go intraocular, and AC reformation was not required when BCL was placed. So case 2 is 18-year-old female, recurrent episodes of redness, watering, history of antitubercular therapy 1 year back. So there was a flight 10 oral keratoconjunctivitis on day 1, but it was not responding, and aggressively peripheral ulcerative keratitis also developed, and after few days, after a week, it turned out to be progressively turned out to perforation. So it is infected with the inflammatory component is also happening. So as the size is 3 by 2.5 mm. So what are the possible options? We can, glue cannot suffice alone. So location is peripheral. Uval tissue prolapse is also there, and uncorrected visual acuity 6/9. So corneal gluing versus patch graft is one doubt. So corneal gluing is available option in this case, but there is a peripheral perforation, the risk of iritis is super high, and also risk of glaucoma. Because of iritis, it can lead to open angle glaucoma, and the tissue is adhered to the conjunctiva. So we went ahead with the corneal patch graft because it provides a good tectonic support, and however, if tissue is not available, then we do not have any option. So we did a Tenon's patch graft in this case. So the measurements were taken, and from the superior sclera, we, after putting the xyloedry, we just took the Tenon's patch graft of 0.25 size oversizing. We dissected the tenons. And after AC reformation and the uveal tissue prolapse were taken care of, it was infiltrated, so we cut the tissue and Tenon's patch graft was placed. We freshen up the margins by the crescentic blade. Patch graft was placed, and we sutured it with the clear cornea. So case, and these are the post-op pictures. At 3 months, the uncorrected visual acuity was 6.9 and corrected distance visual acuity was 6.6. However, there is a little amount of iris tag touching it. So 5-month-old female, right eye keratomalacia, systemic workup, biliary atresia, and cause of vitamin A deficiency. So it was a sterile corneal with secondary infective keratitis. So it was 5 mm in size. So we went ahead with tectonic penetrating keratoplasty. So we freshen up the margins and we take the peripheral graft, around 1 mm of oversizing, and we did a therapeutic penetrating keratoplasty. And also always the host size should be measured after the tissue is totally, so donor tissue cutting should be after the measurements of the host. It is opposite to the optical penetrating keratoplasty. In this, we have to measure the host after fully freshening out the margins, because infiltrates can be there. So, and 1 mm oversizing has been done in this case. And these are the post-op pictures. So case 4 was a patch graft, and so post-operative care, continue antibiotics and antifungal if any causes there, cycloplegic steroids. Conclusion, every case of perforated corneal is different. We have to treat the cause and then go ahead with the surgery, and case-based approach is necessary. Location, size, and state of the surrounding cornea determine the corneal procedure. Thank you.
Thank you so much for a wonderful presentation. Any question from the audience? Yeah.
In your case number 2, you retracted the prolapsed iris in and then you have put that Tenon's graft.
Yes, sir.
Is it correct method, or madam we have to cut it because it is already a case of infection? So it will go in.
So in these cases, we see the viability of the iris first. So if the iris is viable, if you touch the iris and it bleeds, so it is viable. You can reposit that iris. But if it is a very long-standing perforation and there is an ischemic iris, then you need to cut it.
Since it was a recent onset, so we went ahead.
Dr. Sharon, want to?
I think the case, what you're saying is a very valid point. That case, I think, was more like a PUK.
With a sterile corneal melt. Yes.
Sterile melts, yeah.
And if the iris has not been out for, as Nidhi was saying, you see if there's any membrane over it, you can clean it, peel off the membrane, see the viability of iris tissue, then it's fine. Of course, in an infected case, we would ideally, if it's very necrotic, you abscess. But otherwise, you can try to save it as much as possible. So you see, if there's any membrane or something, then you deal with it. But the pathology is very important. Also, in a case of PUK, never forget that you have to treat the underlying cause. So this is a patch. We are doing it to, tamponade, or it's a temporizing method. But unless we treat the underlying pathology, if it's an immune condition, you have to send for the systemic immunomodulation, and that's the thing which will heal it. Otherwise, you'll have it in another area, or that will also melt.
Any other questions? So we'll move on to the next talk by Dr. Parul Chawla Gupta. She is an additional professor at PGI Chandigarh, and she'll be talking on glue and BCL.
Thank you, Dr. Neeti, for this opportunity. So I'll be speaking on Stick Shield Safe, Glue and BCL, the dynamic duo in corneal rescue. So currently available tissue adhesives include cyanoacrylate, which is a non-biological adhesive, and fibrin glue, which is biological. The indications for these are size should be ideally less than 3 mm, located away from the nimbus, and the morphological profile should be concave. Cyanoacrylate glue is used for very small perforations. Mechanism of action includes it undergoes polymerization upon contacting water or weak bases, causing them to harden. And dry conditions are required for optimal polymerization for butyl derivatives with peak bond strength occurring at 2 minutes. So for corneal perforations, up to 2 mm tissue adhesive, sometimes they use cyanoacrylate glue even up to 3 mm, but it's most beneficial up to 2 mm. Then 2 to 5 mm is Tenon's patch graft, AMT, corneal patch grafts or conjunctival flaps. And large can be penetrating keratoplasties. So these are the advantages and disadvantages of various techniques. So if we see that the tissue adhesives, they lead to a lot of vascularization, especially if they are applied in the periphery. And they also have additional costs. But there is no dependency on an eye bank, there is no volume replacement, and risk of rejection is 0. So this is the case of a 63-year-old male with a history of injury with a wooden stick. He had an hypopion, circumciliary congestion, and thinning, dysmetocele. The KOH and gram staining were negative. This was the AIOC picture showing thinning and dysmetocele. We started him on empirical treatment of fortified Vanco and Tobra along with the IP reducing agents. And left eye cyanoacrylate glue with bandage contact lens was done by the disc method. So what were the materials required? We used a cyanoacrylate glue, 3 mm skin trephine, the non-stick portion of a clear opside dressing. We can also use a Surgiwear, antibiotic ointment, the orange stick or the reverse end of a cotton bud, a 1 ml syringe. We can also use a fine cannula, and Vexel or Merosil sponges. So we can do it under topical anesthesia. If the patient is squeezing the eye, we can also give a facial block. So we can use a 27 gauge or a 30 gauge cannula or a needle to directly apply it, or you can use a disc made of a sterile plastic drape, just punch it out with a 3 mm skin biopsy punch, and using the back of the Merosil spear with the antibiotic ointment, we can just lift up the disc, apply a spot of glue on it, and apply it on the, I'll just show you the technique. So this is technique number 1, dry the wound with a sponge and directly put a drop of glue over the dried area. This leads to a lot of accumulation of dry, so it's not very ideal to do it by this technique. Technique 2 is just get a punch biopsy done with a 3 mm trephine, then use the opposite end of a Merosil spear, put some ointment over it, stick it over the disc, and place a glue on the opposite side of the disc, and then place it on the cornea. So you'll get a very fine, thin, smooth layer of glue. Technique 3 is using a 24 gauge cannula. We can use an infant yellow IV cannula without needle used to pick up the disc, done in the similar manner. But technique 2 is the most ideal. So prerequisites are the site of gluing is to be kept dry, that is very important. Debride 1 to 2 mm of epithelium around the ulcer with a spear or a blade or a forceps, because the glue does not stick well to the epithelium. Any lens material, vitreous or foreign body should be removed from the area to be glued. And finally a BCL is required. So this is how we did this glue BCL. In this we applied a portion of the Surgiwear itself. So you can see that white disc. AC was formed, and you can see 2 months post-op that the infiltrates have significantly decreased, the AC is still formed, and the hypopion has disappeared. So this was the post-op AIOC picture. So this was a 50-year-old female with a healing keratitis with a central dysmetocele. So you can see that the Siedel's test was positive. You can see the aqueous coming out in the video. So this was an ideal case for a glue BCL. So ideally all the adhesions should be broken after making a side port. Then we debride the epithelium using a 15 number blade, and with the back of the merosil spear we just apply that glue. You can see how fine it is and how thin it is. After forming the anterior chamber with air, just put BCL. This was a 44-year-old female with a history of rheumatoid arthritis with sterile perforation. So we remove the debris over the perforation with a 15 number blade. And since the AC was formed, we just dried up the surrounding with a merosil or Vexil sponge. And in a similar manner, we applied that glue. Case 4 was a 54-year-old male with sterile perforation secondary to severe dry eye disease. In this also we applied glue. Case 5 was a 54-year-old female with healing keratitis with central perforation. And case 6 was a 48-year-old male with healing post-traumatic paracentral central perforation. So technique modifications can be done. For larger defects, we can use a 10-0 nylon suture which can be used to create a reticulum over which the defect can be sealed, and over that the glue can be applied. And some authors also describe the supplemental use of sodium hyaluronate or a visco maintainer prior to the application of glue in certain situations where anterior chamber is compromised and intraocular contents are tending to prolapse through the perforation site. However, this sodium hyaluronate might have a chance of disrupting and dislodging the glue in the later stages. There's another double drape tectonic patch technique with cyanoacrylate glue used in the management of corneal perforation with iris incarceration. So 2 mm disc is first centered on the corneal perforation to protect the iris. And the large patch is then glued over the central 2 mm patch and covered with a therapeutic contact lens. This successfully seals the corneal perforation without inducing any iritis. So what can be the complications of glue BCL technique? It can cause stromal, endothelial and lenticular toxicity when directly contacting the cornea or the lens. It can cause raised intraocular pressure, possibly secondary to inflammation affecting the trabecular meshwork, and microbial keratitis can be there secondary to prolonged BCL use. It is cyanoacrylate is typically non-biodegradable and requires removal in around 6 to 8 weeks. In fact, after around 1.5 months or so, it starts dislodging if the epithelium has healed. So this was a paper in which there were outcomes of cyanoacrylate tissue adhesive application and corneal thinning and perforation, and larger size of perforation versus the thinning, and single glue application were correlated with higher failure rate. So this is the fibrin glue. We see the components here. So aprotinin is mixed with the fibrinogen and calcium chloride is mixed with thrombin. So it is a biological product containing fibrinogen and thrombin. It is used for smaller defects up to 2 mm and is very effective, as effective as cyanoacrylate, though the bond strength is slightly less. Thrombin catalyzes the conversion of fibrinogen to fibrin in the coagulation pathway, resulting in the formation of a plug. And when applied to the corneal perforation, this plug forms an effective sealant. Disadvantage is that it degrades more quickly than cyanoacrylate glue. It does not have antibacterial properties vis-a-vis cyanoacrylate, which has bacteriostatic properties, and bovine-derived products may transmit prion or viral diseases. So this is another paper in which fibrin glue and cyanoacrylate glue adhesives were both effective in the closure of corneal perforations up to 3 mm in diameter. However, in our experience, we use it for very small perforations. We can also combine it with a T-nonce patch graft, so it can give additional strength to the T-nonce patch graft. So these are the advantages, disadvantages of both the glues. And this is a small video on making the fibrin glue. So the aprotinin is put in the fibrinogen. We need to mix it well, and the calcium chloride and the thrombin are then mixed. After mixing properly, both of them are placed in the fibrinotherm for around 20-25 minutes, and then you just draw it with a needle and then apply. Thank you so much.
Thank you, Dr. Parul. Wonderful cases and wonderful techniques of glowing the eye. Any questions or comments?
Fibrin glue is quite expensive, more than 10K.
It's in the range of 10 to 13K, varies.
So the one from Baxter,
Hmm.
the one from Baxter is around 10,000 to 13,000 depending. There's also the Reliseal available from Reliance. Sometimes it's not available, but that is at least a more economical
Version of that.
option.
Yes.
The only thing is Reliseal doesn't store as well. Sometimes with Baxter you do have the option for a few days you can keep it as long as you don't mix the two components together. Reliseal I've not found to have so much shelf life, so it becomes a single use thing. But it's still significantly less, I think 3 to 4,000.
Yes, 3,000-4,000. Yes.
Just I have one.
Okay, thank
Just
you.
want to share one doubt query regarding the Reliseal actually. When I had a very smooth and comfortable experience. So that's why very difficult if we are in a private practice or if you don't have a bulk of patient and then or economic strange, then Baxter definitely very predictable, very much predictable.
Predictable.
But one of just I'm sharing. That's why I'm asking if anyone in between is good, but price will be the less. Anyone any experience? Okay,
That's
okay,
great.
sir.
Okay.
Because Reliseal actually, I don't have the financial interest,
No, I understand.
but that one, whatever the Reliance one, I have a kids and I'm planning for the ocular surface reconstruction. I'm really shocked. Then
Doesn't
saw
stick
that
as
it's always stuck, and then I had to be open the things for the Baxter one, complete the surgery, but I have to be stage the things of that economical burden to the patient. So that is very unpredictable. That one, the Reliseal one.
I also wanted to highlight two very important points which Dr. Parul mentioned, but people may not realize how important it is. One is if you see her videos of the application of the glue, the de-epithelialization around that area of perforation, is that audible? The de-epithelialization, whether it's with a blade or whatever you're using, some sort of de-epithelialization is very, very important, and also to keep the bed dry, which is sometimes very difficult in a perforation because it's constantly oozing. So they are two of the main reasons for the glue to get dislodged early or not stick. So as she was showing, you have to de-epithelize, and if you're doing it at the slit lamp or in your OPD, one very easy way is you recline the patient slightly and you take 2 Merosil sponges. One is with the sponge tip down, one is with the back of the sponge. And you ask your assistant, whoever, to hold the lid so that they are not blinking and
Exactly.
applying pressure. And then you take your back of the Merosil, pick up the glue with that, dry the bed with this hand and immediately put the glue. Before, almost before the equus has a chance to come out, because that will immediately do. If you use the same hand to be drying also and also putting the glue, by then the fluid has come out and again it doesn't stick. So
Yes.
these are all practical points
Yes.
which putting speculum sometimes is
It's
too much
difficult.
pressure.
Sure.
Yes, too much
It
pressure.
doesn't help. Yeah.
And single layer of the glue, because
Yes,
if you are
yes.
properly
Very
placed,
important.
because
very
we
true.
have a tendency to even also in the learning
2-3
phase of we
layers.
put layer by
up.
layer
Yes.
pulled up the diamond,
Pulled up.
and that causes actually the no holding of the glue for the
And
long
very
time
uncomfortable
and
for the
uncomfortable and dislodgement of the BCL2 also,
Yes.
because
Yeah,
patient
it
comes the
becomes
because there are hipped
corrugated,
up the things and the
Mound.
corrugated the things. So if you appropriately, even also your whatever the cyanoacrylic glue to also or fibrin glue, if you place a simple single layer, it is sufficient enough to hold the perforation.
True, true.
Yes.
As she was showing
Yeah,
in her
ma-
video,
madam was
put
showing
that
is very-
dot and
Exactly.
wait for the crystallization. Give it a bit
Yes.
of time.
Exactly.
Wait for the crystallization. See if there's oozing. If you require, then only put the
Yeah,
lens.
Yes.
Thank you.
Very
Thank you.
beautifully shown. Right?
So
Thank
I
you.
also have one question for Dr. Parul or Dr. Sharon, Dr. Prabhakar. Like, which kind of perforations you prefer to put a glue? There are certain perforations with the slanting edges, certain with the perpendicular edges. So where you will plan a glue, and for perpendicular edges, do you plan something else, or you go ahead with glue BCL?
So less than 2 mm we prefer glue,
Yeah.
and less than 1 mm we can even
Sometimes,
put
you know,
just a
we
BCL.
see immune melts where
Yes.
the edges are vertical. So there is a chance that the glue will go off. So in those cases,
We try with the glue first. If it doesn't stick, We retry with the glue, and if it still doesn't stick, then we
I'll
do
be showing
the
one of
Tenon's
those,
patch.
those kind of cases.
Because it
Basically,
happens
I
in
would
many
differ
cases.
here a bit because, like, if it's like immunological mediated, I would not prefer going for a Tenon patch because
Yeah.
this is what we do. Like, whenever we see there is extensive melt of the
Yes.
cornea, so we do tenectomy around, and we
Tenectomy
do a
around.
bandage. I mean, so fibrin glue.
Fibrin.
It's not fibrin glue.
Cyanoacrylate.
Cyanoacrylate glue application.
Yes.
So preferably, I would not go for. Rather, I would go for a patch graft in such scenarios than taking
Patch
a
graft
Tenon
is
patch.
definitely, I
Yeah.
think, the best.
Yeah.
But due to non-availability of corneas, we just try to avoid that and try to do with the other things available.
In immune med, I think the
But in very
patch
small-
graft will be the most
Yeah,
apt.
so
Yes, that is the
even
most
I
appropriate.
prefer to do
Yeah.
a patch graft for immune melts.
For immune melts.
And
If it-
cyanoacrylate, usually in infected cases, glue is
Yeah,
better.
because
Yeah.
patch graft is most apted in case of the immune med because it will hold the thing and
Exactly.
even healing aggravate the healing too also.
Exactly.
What
yeah.
principle you're using the cyanoacrylate, it doesn't solve the purpose because the immune reaction is going on. So
That
if
is
you
why
do
it
the
keeps
patch
on
graft
melt-
and do the systemic immune
melting.
suppression, I think it does work very well.
But if the perforation is extremely small, I think we can just do away with the glue also.
Yeah,
Even
if
in
it is-
immune mediated conditions.
I agree, yeah.
I mean 2 mm or like that. If or there is no heaped up, most of the time there is a punched out.
Yes, punched
I mean
out.
the iris is there. That lesion is very I mean good appropriate
Yes.
case for the the patch graft one.
So-
if there is a punched up lesion is there.
Yeah, point well taken. So the point is that we have to see whether it is just a perforation or there is a loss of tissue around the perforation as well.
Exactly. Yes.
So we are supplementing, so depending on what is the problem there, then glue is the temporary solution.
Yes.
But we also have another problem of replacing that loss of
Loss of
volume or
volume.
loss of tissue that you have, which the other things like Tenon's or a patch graft would do. And patch graft, again, it has its reasons, which I think we'll be discussing on where to prefer. Yeah.
But then actually, along with that, actually, what we learned from the Gita too also, some perforation means definitely some sorts of the shoot of the inflammation reaction is there. So we have to use systemic immune,
Absolutely.
Yes.
immune suppress the patient. That's the indication for the giving the IBMP or the systemic cyclophosphamide
Yes,
and
yes.
hike up the steroids too also. That's indicated and we have to be, cross consult with your immunologist friends.
Absolutely.
Yes. The basic cause should be addressed first.
Exactly, exactly, ma'am.
These things will work only if the basic cause is addressed. That is what we tell the patients because they try
think
to
this
not
is
go
the
to the rheumatologist. They try to ignore that fact, but we have to re-stress to the patients that that is the cause, that is the issue that is causing your problem.
And sometimes they self-modulate the self-change the dose of immunity. They think I'm doing better, so they up the dose or like that. And that is the actually more inculcating factor to all those, the immune hike up immune reaction. Thank you.
Okay, thank you.
So moving on, we'll now call Dr. Sharon D'Souza for her next talk on Tenon's patch graft. She's a cornea and refractive surgeon at Apollo Hospitals, Bangalore. Go ahead.
Good afternoon, everyone. Thank you very much to Dr. Neeti and AIOS for this opportunity to speak on this topic. I'll be restricting my talk to just a few, as many clinical points as possible for anyone who is already doing or would like to go ahead. So there's no doubt about, and very nicely shown by the previous speakers, that for perforations, we do need to do something about that perforation because there's a risk of infection, there's loss of aqueous, there's hypotony, they can go into endophthalmitis. There are so many challenges that can happen with a perforation. And also shown was that we decide our treatment based on the size of the perforation, which very broadly is absolutely tiny or less than 2 millimeter, 2 to 5 millimeter, and more than 5 millimeter. But the other point that we also have to keep in mind, or rather two, is the location of that perforation and also whether there is any thinning around the perforation, loss of tissue, shelving, as Dr. Neeti was rightly saying, punched out lesions, because then we also have to plan further. Whatever we are doing is a temporizing method, and then we have to try to rehabilitate the patient. So what are our options there? We have already seen cyanoacrylate glue. We have other options of amniotic membrane, Tenon's patch, and a corneal tissue. Now, each of them have its pros and cons, and corneal tissue, no doubt, would be our best option for something which is not amenable to a cyanoacrylate glue. But we do know the scarcity of availability. I think suddenly the mic is working. The scarcity of tissue available to us, And so now we have other ways to at least buy some time for the patient, and very often we may get away with this being the only procedure that we need to do for the patient. So we believe it is a temporizing tectonic solution, and we are trying to be independent of supply challenges for cornea. So what is Tenon's patch graft all about? So it is an autologous tissue. As we are saying, it's the patient's own eye that we are harvesting the tenons from. So because of this, there is a zero risk of any immunogenic reaction which could happen with a corneal patch. So we want to restrict the use of corneal patch where we do not have other options. It is both a tectonic support and also a good volume replacement, as I'll show you. So if you have defects where there's a lot of shelving and just the central area has got perforated, it also helps to fill up that shelving defect and sort of give a good nice contour to the tenon, to the cornea. Of course, it leaves behind a scar in that area. So as I'll show you in some images. The biggest advantages of it is that it's very accessible. There's no shortage of a supply of that tissue. The techniques for doing it are very simple, very easy, and immediately available to us. So if your glue is not working, you don't have to wait for a tissue. You can go ahead and do it. So where is the best place for us to harvest this Tenon's patch? So it's 1 to 2 millimeter posterior to the limbus. We are not going exactly near the limbus. That being, we want to avoid damaging any limbal stem cells there. And also the tenons, which is little away from the limbus, is very rich in vascularity, which helps us, and also very elastic, which also helps us, as I'll show you. You avoid going too posterior. You don't want to damage any other structures. And what is one of the best areas is somewhere between the muscles. So don't go somewhere where you're expecting the recti muscles to be in case you touch any of the fibers. So somewhere between, so superiotemporal, superinasal, inferior. There are a lot of areas and there's a lot of tenons. So you can pick up a lot of tissue. So there's no problem for that. Now how does it work? We are doing in the first day, it is just a plugging. But after a few days, it also brings in some amount of healing by its fluid which it imbibes, the vascularity which it brings in, and acts like a pseudocornea formation and then goes into a scar formation. How do we select a patient for this? So ideally, as I said, the size of the perforation, anything not amenable to a cyanoacrylate glue, or you've done a glue, it is not sticking, then you have to go ahead with other options. It can be for any kind of melts, but if you are suspecting an immune-mediated melt, then as we were discussing, controlling the systemic condition is very, very important. Infections also we are now gradually using, but I am still a little careful in those cases because there's so much else happening. But otherwise you can use it for a number of other conditions. Dry eyes, be careful because the melt itself may keep worsening, but otherwise you can pretty much use it in all conditions. As we were saying, 2 to 6 millimeters, it's an autologous tissue. It also gives volume replacement and there's no rejection risk, which makes it quite an easy tissue for us to use. I think I'll directly go into the technique with the video to show. So this was the patient which I was saying. This patient had a perforation for which we have done a glue, and you can see the glue sitting there. But this is the 5th time that we have applied glue in, about a span of about 10 days because it keeps dislodging in spite of the deepithelializing around, trying to avoid the fluid coming out, all of that. So I'll just pause this 1 second. Right. So if you see the location of the Tenon's graft harvesting, as we were discussing, 1 to 2 millimeters away. This looks much more than 1 to 2 millimeters because this is the posterior edge of where we want, right? And you take about 1 to 2 millimeter of the graft. Even if your graft is, the size of your defect is larger, then you don't need to take like 6 millimeter defect you have, or 4 millimeter defect. It's not that you need to take 4 millimeters of tenons because the tenons, as you apply fluid to it, fluffs up, as I will show you. So this is how we start. Very easy for anyone who is doing a pterygium surgery because you just undermine the conjunctiva and take the tenons from underneath it. Right? So you just make a conjunctival peritomy. That's the tenons over there. You start dissecting, separating it very easily. okay, and I have taken about a 1 millimeter of tenons. Now you'll wonder if this is adequate or not. Okay, next is a very, very important step. We hydrate the tissue. As you keep hydrating the tissue, you will see it will keep fluffing up. It will become more and more, it imbibes a lot of fluid. And why this is important is because we need to stuff it into that defect. Now you see a glue is been removed. Next is, we try to stuff it into the defect. 1 second, we'll pause again. So you try to stuff it into that defect, whatever is there. Part of it may be in the anterior chamber, and that is okay. That is fine, because over time it will compress. So you try to stuff it in as much as possible. If it is again getting collapsed, hydrate it again so that it fills up that defect. Now coming to the suturing technique. What we use here is a figure of 8, 2 figure of 8 sutures. And that's very useful technique, because then your sutures or the bites of your sutures are not coming in your visual axis. So the sutures itself are not going to cause any scarring, which sometimes happens when we have a graft or a defect closer to the visual axis. Then your scar may not be there, but your suture will leave scars. So this is how we do the figure of 8, 2 figure of 8. I'm done, just this video we're done, okay? So if you can see, 1 second. Sorry. Okay, so both are in the same direction. So right to left, you go across, again right to left. Okay, that's all it is. And then you make sure that the cross of the suture, this central area which has to cross, that point of maximum cross has to be on top of where your perforation is, so that it applies the maximum pressure in that area. Similarly, we'll do another figure of 8 in the opposite direction. If that you feel the suture is crossing over the visual axis, we will take the bite further, take it closer to the limbus, not a problem. Put in your air AC, remove iris, which is making sure that the iris which is adherent to that opacity is separated from it, and go ahead. Okay, so same thing. Okay, that's all it is. It's a very simple procedure. If you feel it's coming out, put it in. You can also, if you feel that there's some leakage from the edge, add on a fibrin glue on the edges. Now, one very important clinical point which I want to add before I close is that in the early post-operative period, this graft fluffs up. So it looks much bigger or larger than what you had put in, and it looks a little scary or not very beautiful, and I'll just show you, okay? So this is about a month after doing Tenon's patch graft, and you can see that it is still quite fluffy, but there is a lot of volume replacement that happens along with it, and you can see the size of the cornea the thickness of the cornea goes back to almost normal. Of course, you can have a lot of complications which may be leak, or you have to repeat it, hemorrhage, or a pseudocornea formation, but these are relatively less. So the take-home message being that it's a useful technique for medium-sized perforation. It's a fairly simple technique to do, no chance of a rejection or immune reaction, and an easy technique to master. So definitely something we can all keep in our armamentarium for those patients where we have to use in an emergency. It's a very useful technique. Thank you very much.
Thank you, Dr. Sharon. A wonderful video and a technique. Any questions from the audience? Or any comments?
So one thing that I would like to add is while harvesting the tissue, is it working? So while harvesting the tissue, one has to be very careful because the tissue is very sticky. So every time you try to manipulate it, it will stick to your instruments, and it becomes very difficult to work with such a sticky tissue. So what Dr. Sharon had shown, that when you wash it with fluid, it fluffs up, and then the stickiness also goes down, and this is how you can go for the repair.
Another point which I want to mention is that when you are stuffing the tenons in the perforation, you should be very careful because behind it is the iris and the lens. So one of our resident was doing this very enthusiastically. He was putting in and injured the lens. So we have to be very careful for that also.
Now I'd like to invite Dr. Neeti Gupta, mending the clear shield, corneal patch graft and perforations.
So a very good afternoon to all. I will be talking on corneal patch graft after glue, BCL and tenons. As we all have seen that corneal perforation is an emergency and we need to mend it as soon as possible because of the risk for endophthalmitis. And larger perforations, we cannot treat those perforations with a glue or an AMG. It is difficult to do that, or a tenons patch graft. So in such cases, corneal patch graft comes as a savior and it is a definitive treatment for repairing these perforations. So what are the indications where we can do it? One is the rheumatological diseases like rheumatoid arthritis, SLE, Sjogren syndrome. Then trauma, also persistent epithelial defects which we see most commonly in neurotrophic keratitis, and infections. I would say that infections would be my first indication because during infections, in the infections we do not prefer to use a tenons or an AMG. We can use a glue BCL if the perforation is smaller. So what are the disadvantages of these corneal patch grafts? One is that if the suturing is not meticulous and if we are doing a very tight suturing, it may cause a very high astigmatism. Also, these grafts are again collagen and corneal replacement, so they may melt and there may be rejection of the endothelium. Also, very important point which Dr. Sharon also mentioned, that there is paucity of corneas in our in the country like developing countries like India. So we don't have easy accessibility of these corneal tissues. So how do we prepare these donor patch grafts? So we have corneal trifines. The range is from 6 to there may be 12, 12.5. Also, for a smaller perforation, we have dermal punch, which the dermatologists they use for a skin biopsy. They come in a range from 2 to 8 millimeters. So we can use, if the perforation is larger, we can use a trifine, or if the perforation is a smaller, then we can use a dermal punch. Also, we can fashion our donor cornea into a banana patch graft for a peripheral perforation using the same trifine. We can cut at two different positions to make it a half moon or a banana shaped graft. Now, what are the suturing techniques? One is mostly we do a single interrupted suture like we use for a keratoplasty. But there's a very interesting technique mentioned by Zhang et al. This he has done for very small perforations around 1.5 to 1 mm, where he has used a cornea for sealing those perforations. So he has mentioned a continuous suturing, like in one go, he's suturing both the ends along with the cornea, shaping that cornea into a conical patch. So this is another interesting technique which I found out. And so what is the technique of doing it? I'll show a video. So first of all, we measure the size of the perforation, and then we make a side port to enter the antechamber and form the antechamber with a viscoelastic. Then we should remove all the membranes and the necrotic tissue around the perforation. And this is how we check the viability. The iris is not bleeding at all, so that means this is a necrotic tissue. So we cut it and release all the iris adhesions. Here I'm marking the size of the area. I'll dissect all the necrotic tissue, and then with the same size of the trifine, I'll cut the donor. I have cut the donor tissue. Now we release all the adhesions. And since this is a peripheral perforation, so here I prefer to take the donor cornea from the periphery, where we have a you can see there is a corneoscleral junction, so that we can respect the limbus. I'll show you one of my cases in the subsequent slides where we didn't do this. And since the cornea is thicker in the periphery, so it is better to take from that side only. So excessive sclera I have cut, and then I've sutured the cornea, like interrupted 7-8 sutures, and then we bury it. Finally form the anterior chamber. This is another case. This was a patient came with after a pterygium surgery. So you can see there is a ischemic sclera along with the corneal thinning and perforation, and iris was incarcerated. This was around, like, he came after 2 months. So this is how we did a surgery in this case. The corneal perforation was repaired in a similar manner. The only different thing I did here was I used a lamellar patch graft because the cornea was very thinned out here. So the basic purpose of suturing a cornea is that the epithelial alignment should be good. Otherwise, the epithelium will not heal at that place. So I'm releasing all the adhesions around the medial rectus muscle. Then again, forming the anterior chamber with a viscoelastic. And here I'm freely dissecting, like I'm lamellar dissecting the cornea after punching it at the corneoscleral junction. Then again removing the membranes and cutting the necrotic iris, and here all the adhesions behind the cornea, iridocorneal adhesions, we are removing, and then I'm suturing this lamellar cornea at the periphery. So the different, one thing which different I am doing here is that I am bringing the tenons, vascularized tenons over that ischemic sclera, so that there is the further melting of the sclera is inhibited. So I am just using a 8-0 vicryl. I dissected the tenons and then just sutured it at the limbus, and then dissecting the conjunctiva. After this, we did I always do a tarsography in such cases. So this is the post-op picture. So after 2 weeks, there was a medial tarsography intact over that place, and the surface was beautifully epithelialized. And this is the 3 months old picture of the patient with the best corrected visual acuity of 6/12. This is another case of fungal corneal ulcer where we did a small corneal patch. Now usually in infections we do a corneal patch, but in immune males I usually prefer a tenons now. So this is another case of viral infection, necrotizing stromal keratitis with a melt inferiorly. You can see infiltrates are not much, but here we did a corneal patch graft. This is another patient with a wooden stick injury. So there was no cornea at that place. So there was around 3 mm corneal defect, which we repaired with a corneal patch graft. And then after 3 months, we did a cataract surgery. And this is the 6 months old picture of the same patient. With 6/6 vision. So here the removal of the suture is also a very important thing. So I usually prefer to remove, if the sutures get loose by itself, we remove it, or I remove these sutures like after 8 to 9 months, not before that. This is another case of a Murren's corneal ulcer, peripheral melt. So here we did a banana patch graft. So what is the post-op treatment after doing a corneal patch graft? In cases of infection, we always scrape those patients, and according to the organisms, we give either an antibiotic or an antifungal. In viral males, we give oral antivirals 400 milligrams 5 times for 2 weeks, followed by 400 milligrams BD for a year. In rheumatological diseases, along with topical treatment, we have to give oral immunosuppression in these cases. And in neurotrophic males, we usually do a tarsography. And in cases of aqueous deficiency, dry eye, I usually prefer to do a punctal occlusion after checking the reflex secretion in those patients. Oral doxycycline helps a lot to prevent these immune melts in these cases. The complications which can happen is recurrence of the infection in the graft, wound dehiscence, and sometimes there can be recurrent epithelial defects over the graft. So this is the case I was mentioning where I took a central cornea. These are the very early cases when I started corneal patch graft. So we took a central cornea, and when we sutured it at the periphery, so you can see cosmetically this is not looking very good. This is another case of a young girl, around I think 14 years old girl with bilateral immune melt. She was not able to open the eye. So these are the on-table pictures. So this was the pre-op right and left eye with iris incarceration and bilateral melts. And this time I didn't had a cornea, so I used a glycerine preserved cornea in this case. And this is the post-op picture of the same patient at 6 months. You can see filamentary keratitis, loosening of sutures. So she had a very severe dry eye. So after this, we did a punctal cautery, and this is 3 years old picture with 6/6 corrected vision in both the eyes. And we offered a pupilloplasty, but the patient is not ready for the surgery now. So to conclude, corneal patch graft is a valuable globe-saving procedure for large corneal perforations, and they provide a good tectonic support and restores the ocular integrity. It may serve as a bridging procedure. Sometimes we don't have any option, central large perforation, and we don't have a good cornea, so we can first do a corneal patch graft, and later on with a good optical grade tissue, we can do a optical keratoplasty. And it is usually preferred for defects more than 3 millimeters. And a proper case selection, meticulous surgical technique, and close post-operative monitoring are the key for successful outcome. Thank you.
Thank you, Dr. Niti, for an excellent presentation. If anybody
Any
has any questions.
I'll ask a question. In the interest. I think for anyone who is handling these cases, sometimes that iris tissue has so much memory that once it's out and you push it in, then every time it will tend to keep coming out. So whether it be EMG or Tinans, or whether you're doing a patch graft, it is sometimes very difficult to start your suturing because you're scared the iris tissue will come into your bite.
Yeah.
So what are your tips for, or how would you manage such a situation?
So either we can use a visco-cohesive OVDs to, like, create a space between them, but still it is very difficult. It also comes out. So first of all, we take, put like 2 or 3 sutures, and then we can release the iris once we can form the antechamber.
Yeah, stay sutures are very useful. You can also, if you want, keep an iris repositor there to push it down and take your bite. But yeah, whatever said and done, try to avoid the bite through the iris.
Iris, yeah.
And if by chance you've taken your bite through and you've not realized it, then when you're trying to release the iris, be very careful. If it's taking more than usual effort to pull away, just rethink, recheck that you've not taken your bite through it. Otherwise, you may tear the iris or have a dialysis through it.
Ma'am, I had a question. Wherein
I think he's asking some question.
No, you please, you can proceed.
why did we choose the lamellar graft there?
So because the edges of that cornea was very, very thin. So if I would have taken a cornea from the periphery of the donor cornea, it was very difficult to suture. And we always have to do a epithelial alignment first. So a lot of tissue would be bulging down. That's why. And the patient did very well after that.
Yeah, just I'm just sharing one of the experience that Dr. Sharon was telling. So in that scenario, what I prefer is we have a normal tendency to give the visco and AC should be formed, then put the suture. So in that scenario, there is the bulging and the gushes of everything coming out. So then that scenario, just what the madam was telling, we can have the dispersive OBD, just like coating of the endothelium on layer. Don't tends to be full the AC, number one, or you can put a very simple one small air bubble. Air bubble in that sense works very good, because they work at the tamponade, a small one, then put a 1 or 2 stay suture, and then we just wipe gently whether it is stuck or not, and then rest of the thing is very smooth. Otherwise, if you give the visco and try to tense, then it will be gives away from here and there and the peeping of the iris. And second thing is that Dr. Prabhakar, what the telling ma'am, in that scenario, actually we nowadays prefer the lamellar one, and we try to be, if the cases is there, we clubbed up with the manual dissection. However, the initial preliminary, we have the 400 of, or approx first, the punched out of the dissect graft is there. So we are just keep this one and use it as a patch graft.
Very true. Yeah.
Just to add to what we had discussed previously regarding the glue BCL. So if at all we are doing glue BCL on slit lamp in some patients where we see that there is a little larger size dysmetocele, so be very careful. Rather take those patients in OR rather than doing it on slit lamp, because the moment you are going to, make it dry, it's very likely to perforate on slit lamp itself. So it's always a good idea to take such patients on slit lamp to the OR and then do the glue BCL. And one more thing that I would like to add was, like, in glue BCL itself, like many times what we are doing right now is like we are just reflecting the epithelium, as ma'am said, that we have to debride the epithelium around, because that adds to the strength. So what we are doing now is we are just reflecting those epithelial cells, and we are reflecting it onto the desmatocele. And then we are putting glue everywhere and overlapping it with the part which is well, formed areas. And that is how it's working pretty good now. So.
I request Dr. Neeti to play a video on tectonic PK.
Dr. Vikas Mittal. Yeah. So he could not make for the conference, so he has sent a video. We'll just play that. So the last option left with us for a larger perforations, they are therapeutic keratoplasties. So I'll just play a video. completes the spectrum from glue, BCL till keratoplasty. Any questions or comments from the panelists?
I think one very important thing, beautiful video. I'm not sure if it's yours, Niti, but I think the PI which was made, if you see, there were multiple peripheral iridectomies done. So by convention, I think most of us would do at least 2 large PIs. In a case which is an infective case, you're doing a tectonic PK because these patients have a lot of inflammation. They tend to get a lot of peripheral anterior syndicate. IOP will be going up. So we tend to make PIs. The challenge though in these cases is that sometimes if you're over aggressive with your refilling of either viscoelastic or fluid, then that will go back and then your AC will not be forming after a point. And it will be difficult to form the anterior chamber at the end of the case. So PIs are very important to do, but also remember, and that's I used to tell fellows in training, remember where your PIs are and avoid going and filling in fluid from those regions, otherwise you might go through the PI, damage the lens, things like that. But very, very nicely shown, yeah.
So if no questions, then thank you to all the speakers, Dr. Sharon, Dr. Prabhakar, Dr. Parul, and Dr. Pranita. And I thank the audience. Thank you so much. Let's have a group photograph. I will ask the audience also to participate in the come and